are here at HIM 17 talking with Dr. Michael Hodgkins, who is the CMIO of the American Medical Association. Thank you for joining us today.
Thank you for having me.
So let's talk about the mounting frustration that physicians are feeling with their EHRs. What are some of the specific, really big frustrations that they're grappling with, and how did they occur?
Well, it goes back to a study that AMA did with the RAND Corporation in 2013, where we were interested in learning about the sources of satisfaction and dissatisfaction that physicians experience. And the number one source of satisfaction clearly was delivering high quality care. Anything that interfered with that was a source of dissatisfaction, and unfortunately the EHR was high on that list. And the reasons for that were that physicians felt it really distracted them from interacting with their patients, that they were spending too much time at the keyboard, doing data entry and related work, and not enough time in face-to-face patient care. And by most physicians' perspective, that means you're not doing your job. You can't deliver high-quality care if you're not looking at your patient, interacting with them, and really looking for those non-visual cues as well as the visual cues that really go into your thinking about how you want to deal with that particular patient. What are the sources, specific sources of this? Well, I spend too much time. I spend twice as much time, and we've actually examined this, and there's been reports about this that the AMA has written recently. Physicians spend twice as much time with their EHR and paperwork as they do with patients. They spend up to a week's time every month outside of the clinic on their EHR. There's a loss of productivity, and by some measurements, the loss of productivity is the equivalent of 7 medical school classes.
Wow.
So, and that's over a 3-year period, so that's not necessarily annually, but the point is, if you're thinking about the workforce of the future, we're not on a good trend line. If we're losing productivity and we're having that much frustration and burnout. Physicians are literally burning out at a rate much higher than the population at large. And burnout means I'm going to leave practice early, or I'm just not going to be as engaged, and I'm going to lose touch with what brought me here, which was this. This was a calling to help my patients, which is what physicians have always been about.
And the mounting regulatory burden really doesn't help anything. I mean, MACRA was a bipartisan piece of legislation that certainly had good intentions behind it and was largely heralded as a step in the right direction. But it certainly comes with its set of burdens.
Well, although I will, first of all, the AMA supported MACRA.
Right.
And MACRA actually has done some things to relieve the burden on physicians by consolidating quality measurement programs, by sort of putting a stop on the evolution of meaningful use. So the regulatory burden, you're quite right, and I often tell people, don't blame the EHR vendor for everything, right? Recognize that the meaningful use program, which preceded MACRA, incorporated a lot of requirements that weren't necessarily the best choices for most physicians, but the vendors had to include those requirements to be certified. So a lot of the extra data entry and spending time at the keyboard and all the clicks, have as much to do with the regulation as the design of the software. So MACRA actually potentially represents an improvement in certain respects. It really depends on how it's executed, going forward. And clearly the vendors need to do more to improve their design.
Well, that was going to be my next question. As much as it's a physician's responsibility to know and understand the rules and to execute properly on a daily basis to comply, there certainly is a role that EHR vendors can play in facilitating success with any regulation.
Absolutely, and that gets back to the issue of good design. And I think most of the reputable vendors are really engaged in trying to make that happen. But in order to really see a substantial progress, other than what you can do just by improving the user interface, we're going to have to see some background machine learning or artificial intelligence operating that can help to reduce the data entry requirements on the physician, assuming we can get the data from other sources. And those sources can be other physicians, hospitals, but increasingly those sources are going to be the patient consumer. In this world of connected health that we're looking forward to, the patient is going to be more engaged in their own care, especially patients with chronic disease. And the opportunity that it presents us is that the patient doesn't have to come to the clinic for everything, right? They can stay home, they can stay at work, they can stay with their families, and they can monitor what's happening. Blood pressure is a perfect example. Yep. The opportunity exists now for patients to monitor their own blood pressure over time, assuming the devices are accurate. There's even been recent research that shows that patients can titrate their own medication. So they can actually do this independently of the physician. Obviously, there needs to be a connection back to the physician so the physician knows what's happening, but it can all be done at a distance. And when you think about it, you'll probably be more effective. I practiced medicine for 10 years, and a lot of my patients had hypertension. I would see them every 3 to 6 months, depending on the circumstances. A nurse would measure their blood pressure. I would measure their blood pressure. That's 2 measurements. On the strength of those measurements made under who knows what circumstances. What happened to the patient that morning? Were they under stress from something that happened before they arrived? Are they just stressed because they're at the hospital, the clinic?
Did they absentmindedly have their morning coffee before they came to see you?
Right. But on the strength of those 2 measurements, I would make treatment decisions about possibly adjusting their medication. I look back at that and I, have to kind of, ask myself, what were you thinking? Because those 2 measurements in the scheme of things weren't all that important and could have been very misleading. Now you can have continuous measurement, but the trick is not to just create a flood of new data. These solutions have to be able to produce actionable information, not only for the patient consumer, especially if they're going to be making adjustments in their own care, but also for the physician and the broader healthcare team. The physician doesn't have to do everything. You're dealing now with more team-based care. You're dealing with the opportunity for virtual team-based care. Perhaps what the patient really needs is to talk to the pharmacist, or perhaps what the patient really needs is to talk to a dietitian. But the physician needs to be in the loop because ultimately you want to preserve that very important relationship that a patient and physician have together.
Dr. Hodgkins, thank you so much for your time today and your perspective. It's been a pleasure.
Thank you very much for having me.
Indeed. You're watching HIM 17 TV.